Good evening, everyone. Good evening, everyone. I'm thrilled to welcome you all to the webinar, Microvascular Complications of Diabetes. It is my pleasure to introduce our speaker for today's session, Dr. Abhishekh Singh. Dr. Abhishekh Singh, MD pathologist with over 7 years of experience in diagnostic pathology. Doctor completed an MD in pathology from Maharashtra University of Health Science, Nashik, after an MBBS from Dr. B.R. Ambedkar University, Agra. Dr. Abhishek has extensive expertise in histopathology, cytopathology, hematology, and oncopathology, and has been actively involved in clinical diagnostics, teaching, and research, with several research publications and national conferences presentations. Doctor is also a member of Indian Association of Pathologists and Microbiologists. We are delighted to have you, Dr. Abhishekh Singh, with us today to share your valuable insights. Over to you, Doctor.
Thank you so much. Good evening to all of you. Thank you for the introduction. So I hope you all are getting benefit with these webinars, which are conducted by doctors and organized by Mediversal. So my today webinar topic is microvascular complication of diabetes. So we'll start with a case. There's a 52-year-old diabetic patient present with a progressive vision loss, proteinuria, and numbness in feet. What can be the single underlying process? So patient is diabetic and he has progressive vision loss. It means retina is involved. He has proteinuria. It means there's a kidneys involved. There's a numbness in feet. It means peripheral nerves are involved. So I hope you all understand this case. So the single underlying process is the complication of diabetes, especially the microvascular complication, in which there's a diabetic retinopathy, diabetic nephropathy, and peripheral neuropathy. So we'll start the class with a microvascular complication of diabetes mellitus. So introduction and prevalence. Diabetes mellitus is a very common and very serious metabolic condition characterized by chronic hyperglycemia and glucose intolerance due to the impaired insulin secretion or its action. The majority of patients of diabetes, they are affected by either microvascular complication or macrovascular complication. The term microvascular means that either capillaries or arterioles, or macrovascular term means there's a large artery involvement. The microvascular complications are quite common and it is around 52%, and the macrovascular complications are around 29%. So the microvascular are more common than macrovascular complication. The microvascular complication usually are responsible for morbidity. However, the macrovascular complication are responsible for the mortality. So mortality usually caused by macrovascular complication of the diabetes. So in today's webinar, we will understand the mechanism of microvascular injury in the diabetes. We recognize the pathological changes in diabetic retinopathy, nephropathy, and peripheral neuropathy in diabetic neuropathy. We discuss the clinical features and its complication. We review the screening and modern treatment strategy. So now epidemiology. The diabetic retinopathy is the most common microvascular complication, and it is the leading cause of new blindness in the working age adults. And around 35% of the patient with diabetes develop retinopathy. Now coming to diabetic nephropathy, around 20 to 40% patient with diabetes develop nephropathy, and it is the leading cause of end-stage renal disease. Now coming to diabetic neuropathy, the diabetic neuropathy is the most common cause of peripheral neuropathy out of all causes of peripheral neuropathy. And diabetic neuropathy is the most common chronic complication of diabetes. Overall, most common complication of microvascular are retinopathy, but most common chronic complication is diabetic neuropathy. Then 50% patient, they develop after long-standing diabetes. And the distal symmetrical polyneuropathy is the most common diabetic neuropathy presentation, in which distal muscle group involved. So timeline of the microvascular complication. So in type 1 diabetes, because it's developed very early, so it takes 0 to 5 years to getting early microvascular changes. It takes 5 to 10 years to develop retinopathy and neuropathy. And it takes 10 to 15 years approx to for getting nephropathy or develop some advanced complication. Now, pathophysiology of the microvascular damage. The main culprit of the microvascular damage is the advanced glycation end product. It is the primary point from where microvascular damage start. So we'll discuss it in further. Now, the synthesis of advanced glycated end product. The synthesis of advanced glycated end product is the non-enzymatic process. In diabetes, there is a hyperglycemia, so due to which there is a more glucose level, which cause more glucose-derived metabolite synthesis due to glucose metabolism. And the glucose-derived metabolites are glyoxol, methyl glyoxol, deoxyglucosone. When they are high, they get combined with the amino group of intra or extracellular protein. And with this interaction, they form advanced glycated end products. So this advanced glycated end product have two type of effect. Either they bind with the receptor and the effect are called receptor mediated effect, or there are non-receptor mediated effect. First, we'll understand the receptor mediated effect. Now, this advanced glycated end products, they combine with the receptor of advanced glycated end product, and these receptors are usually found over the macrophages, and they are also found in endothelium, T cell, vascular, smooth muscle cell. And due to this interaction of advanced glycated end product and its receptor, there are release of many cytokines and the growth factors. The main cytokine is the transforming growth factor beta, which cause deposition of excess basement membrane material, which ultimately cause the thickening of the blood vessels. And now the growth factor, most common growth factor is vascular endothelial growth factor. This vascular endothelial growth factor cause neoangiogenesis, which is the most important step in developing of diabetic retinopathy. Then the second effect of this receptor-mediated effect of AGE is generation of reactive oxygen species in the endothelial cell. When glucose goes in the mitochondria, there is a oxidative phosphorylation occur, due to which there is a formation of reactive oxygen species, which ultimately cause damage in a endothelial. And due to this damage, the vascular permeability increase, which further cause many changes in a vascular endothelium. Now, third effect is increased procoagulant activity. The AGE also enhance the procoagulant action by suppressing the plasminogen inhibitor, which ultimately cause conversion of the, which cause atherosclerosis in further process. Then there's a deposition of extracellular matrix synthesis. And then there's a proliferation of vascular smooth muscle cell is also a effect of advanced AGE, advanced glycated end product. Now, the non-receptor mediated effect of advanced glycated end product. This advanced glycated end product are directly bind with the type 1 collagen, which are found in large blood vessels. And after this interaction, they cause damage to the elasticity of the blood vessel, due to which there is a increased predisposition to the stress or endothelial injury. And sometimes these advanced glycated end product combine with the type 4 collagen, which found in the basement membrane of the blood vessels. And after making this AG modified matrix with type 4 collagen, there is a decrease in endothelial cell adhesion, which cause increased vascular permeability. Ultimately, there is an extravasation of the fluid. These AG modified matrix component also trap the LDL, and these LDL get deposit in the tunica intima, and they accelerate the atherosclerosis. Now, the activation of protein kinase C. Due to this intracellular hyperglycemia, there is synthesis of diacylglycerol, which is an enzymatic process. And this diacylglycerol is activate the protein kinase C. And this diacylglycerol is formed by the action of phospholipase C over the phosphatidyl over the IP3 inositol triphosphate. And these protein kinase C, they cause vascular endothelium damage, and as endothelium damage, and then they stimulate the vascular endothelium to secrete to cytokines and various transforming growth factor beta and vascular endothelium growth factor, which further cause damage to the vascular endothelium, and they further lead to the microangiopathy. Now, due to this hyperglycemia, it also predisposed to oxidative stress and disturbance in the polyol pathway. If there's a high intracellular glucose, they get converted to the sorbitol, and this process is the polyol pathway. So if there's a high sugar, the high sorbitol will form, and the high level of fructose will form. And in conversion of sorbitol to fructose, there's a requirement of NADPH. So in diabetic patient, the NADPH get deficient due to overutilization in conversion of sorbitol to fructose. However, these NADPH is required for reduction of oxidized glutathione to the reduced glutathione. And this reduced glutathione is a very potent antioxidant. So in diabetes, there is a low deficient in NADPH, due to which there is a less reduced glutathione production is also less. So ultimately they cause more oxidative injury. Now, the pathophysiology of the vascular damage in diabetes. This is the lumen, this is the endothelium, this is the tunica intima and media. When there's a hyperglycemia, the glucose goes to the endothelium. In endothelium, there's a mitochondria, which ultimately do the oxidative phosphorylation, and they form reactive oxygen species and numerous ATP. So now these reactive oxygen species also stimulate the protein kinase C, and these protein kinase C stimulate the endothelium to secrete the growth factor like vascular endothelium growth factor, which cause angiogenesis. And these protein kinase C also activate the endothelin, which cause platelet aggregation. And these protein kinase C through endothelin also activate the nuclear factor kappa B. And nuclear factor kappa B has role in increase vascular permeability. So they cause adhesion of monocyte and then migration of monocyte. So monocyte comes to tunica intima and it converted to macrophages. Now these macrophages, there's a LDL, or due to increased permeability, LDL will also comes to the tunica intima. Then macrophages and LDL get combined and they form foam cells. And foam cells secrete the growth factor. These growth factor act on a tunica media. So there is a proliferation and then migration of smooth muscle. Ultimately, these foam cell and these smooth muscle cells and the platelet aggregation of the platelet, they all collectively cause some vascular changes, and they do the atherosclerosis and endothelium dysfunction. So now we come to our first microvascular complication, which is a diabetic retinopathy, and it is a overall most common microvascular complication of diabetes. So diabetic retinopathy, most common microvascular complication, and it is the major cause of preventable blindness. The risk factor is the duration. The longer the duration, the more the chance of to develop diabetic retinopathy. The poor the glycemic control, more the chance of diabetic retinopathy. Hypertension and dyslipidemia also are the risk factor for diabetic retinopathy. Then pathogenesis. In this, there's a retinal capillary basement membrane thickening happened. There's a formation of microaneurysm due to the injury in a capillary endothelium. So due to this endothelium damage, there is an increased vascular permeability. Ultimately, they all cause retinal ischemia. So classification of the diabetic retinopathy. There are two broad classification. One is non-proliferative, other is proliferative. One is early and next is advanced. So the mild non-proliferative diabetic retinopathy, then moderate non-proliferative diabetic retinopathy, then severe non-proliferative diabetic retinopathy are the early case, and the advanced case is proliferative diabetic retinopathy. So now fundus photograph. This is the first one is the normal fundus photography. We can see here, this is an optical disc. Here is the macula, and these are the blood vessel. These are totally normal fundus. And in the first stage or mild non-proliferative diabetic retinopathy, we can see here that vascular damage is started. There is a small microaneurysm and vascular dilatation is started. Then in moderate non-proliferative diabetic retinopathy, due to the vascular dilatation, the fluid due to damage, there is an increased vascular permeability and fluid leakage started. So these are the exudates, and these exudate are the hard exudates. And then in severe non-proliferative diabetic retinopathy, due to the leakage in the macular area showing some bleeding spot, and these exudates are the micro infarct in the retina, look like a cotton wool spot. And then last stage 4 or advanced stage is this. In this, there is a pre-retinal hemorrhage happened, and because there is a vascular proliferation in this proliferative diabetic retinopathy, there is a new blood vessel forming start. So the new blood vessel are more prone to leakage and damage. So the hemorrhage getting start in this stage. So in early stage, microaneurysm is the earliest retinopathy lesion. Dot and blot hemorrhage, hard exudates, and cotton wool spots we can see in early stage. However, in advanced stage, there is a retinal neovascularization, vitreous hemorrhage, and retinal detachment. Now, diabetic macular edema. It is the major cause of visual impairment. This is due to the leakage of fluid from the retinal capillaries, and they get deposited in the macular area, which cause macular edema. It can occur at any stage. And the main symptom is blurred vision, floaters, sudden visual loss, and the clinical finding is retinal thickening or central vision loss. Then screening recommendation in type 1 diabetes, because it developed in early stage, in early age. So after 5 years after diagnosis of the diabetes, we have to start screening for fundus. However, in type 2, because it diagnosed very late, so as it will get diagnosed, we have to start the inspection or start the examination for fundus. And then annually, we have to do fundus photography. Now, treatment of retinopathy. The glycemic and blood pressure control is the primary treatment, and there is no surgical or laser treatment required for early diabetic retinopathy. However, in advanced or proliferative diabetic retinopathy, we need to do laser photocoagulation, and which block the leakage from the blood vessels. And then we can give intravitreal anti-VEGF therapy like ranibizumab, aflibercept, and bevacizumab. They block the vascular endothelium growth factor, which ultimately stop the neoangiogenesis. Then vitrectomy is also advised for severe vitreous hemorrhage. Then diabetic nephropathy. So, diabetic nephropathy defined by the presence of persistent albuminuria, which is more than 300 milligram per day, and progressive decline in glomerular filtration rate and elevated blood pressure. So, the high albumin must be confirmed at least twice occasion in 3 to 6 month interval, because sometimes the high albumin can be caused by some other condition like fever, like due to some acute inflammatory condition, it can be rise. So it should be confirmed twicely in 3 to 6 month interval. Now, epidemiology. The 20 to 40% of diabetic patients develop diabetic nephropathy, and it is the leading cause of end-stage renal disease worldwide. The end-stage renal disease, when we call end-stage renal disease, when the GFR is less than 5% of the normal GFR, which is 90 to 120 ml per minute per body surface area, it's called end-stage renal disease. So this nephropathy, diabetic nephropathy, is more common with the long duration of the diabetes. Like if after 10 to 15 years of age of diabetes, there's a more chance of diabetic nephropathy. With poor glycemic control, there's a more chance. With hypertension and even in genetic predisposition like ALR2 gene polymorphism, these are the aldose reductase 2 gene, and then ACE gene polymorphism, high vascular endothelium growth factor gene expression, and receptor for AGE gene polymorphism. In type 1 diabetes, it is usually developed after 10 to 15 years of disease, and in type 2 may usually present at diagnosis because of already hyperglycemia exists for years. Now, pathophysiology or metabolic changes. There's in diabetic nephropathy, there's a two type of changes occur. One is a metabolic changes, other is a metabolic and then hemodynamic changes. In metabolic changes occur at a cellular level, and hemodynamic changes occur at a vascular level. So in metabolic changes, there is a polyol pathway activation. This polyol pathway can due to this polyol pathway activation, there is a more sorbitol synthesis, which ultimately cause more utilization of NADPH. So there is a less NADPH available for conversion of oxidized glutathione to reduced glutathione. So it causes oxidative stress. Then advanced glycated end product. This responsible for all vascular endothelium damage and reactive oxygen species production. Then protein kinase C activation. This is responsible for production of cytokines and the growth factor. Then oxidative stress itself, mitochondria is in hyperglycemia, mitochondria start more producing reactive oxygen species. And due to endothelium damage, there is a less nitrous oxide synthesis, which cause vasodilatation. So these all ultimately cause the cellular level changes. Now the hemodynamic changes, it occur at a blood vessel level. So in chronic okay, first we'll discuss this structure. So this is our glomerulus. So this is the efferent arteriole, and these are the capillaries in the Bowman's capsule. These are the efferent arteriole. Now these Bowman's capsule lined by a parietal layer and visceral layer, which is formed by the podocyte. And now there's this Bowman space open in a proximal convoluted tubule. Then there's a descending limb of loop of Henle, then ascending limb of loop of Henle, then it is a distal tubule. So there is a specialized epithelial cell, which is macula densa. They present in a distal tubules. And the specialized cell present in a efferent arteriole, these are the smooth muscle cell, juxtaglomerular cell. They both act for tubuloglomerular feedback. The function of macula densa is to stimulate the juxtaglomerular cell to secrete the renin, which ultimately cause efferent arteriole constriction. So due to renin, there is a efferent arteriole constriction. Ultimately, there is a more increase in GFR. So in chronic hyperglycemia, there is an increased glucose in the blood vessel. So increased glucose filtration in a kidney. Now, due to high glucose filter, there is a more sodium and glucose reabsorption in proximal convoluted tubule. Usually 60 to 65% of the glucose are reabsorbed in PCT. However, in diabetes, there is a more reabsorption because of more glucose secrete in the Bowman space. So the sodium, due to more sodium and glucose reabsorption, the less sodium and sodium chloride will delivery till the macula densa, and macula densa is the chemoreceptor. They sensitize by the less sodium ions. So they stimulate the efferent arteriole to start secreting renin. So, and due to the tubuloglomerular feedback, first change is there is a dilatation of efferent arteriole. So there is a more and more blood flow in the glomeruli. And then due to activation of renin-angiotensin system, there is a efferent arteriole constriction happened. Due to efferent arteriole dilatation and efferent arteriole constriction, there is an increased intraglomerular pressure, which ultimately cause glomerular damage. So due to this, there is a albumin leakage start, which is microalbuminuria, 30 to 300 milligram per day. They start a feature of diabetic nephropathy. Then in pathogenesis, there are only 4 main steps. One is the efferent arteriolar dilatation, and second is efferent arteriolar constriction due to the renin-angiotensin system. And due to renin, there is a efferent arteriole constriction. So ultimately, the glomerular pressure will get increased, and they all collectively called glomerular hyperfiltration, which cause glomerular injury and protein leakage. So renal pathological lesion. There are many important pathological lesion found in diabetic nephropathy. In glomeruli, the first lesion is basement membrane thickening, and second lesion is diffuse mesangium sclerosis. Third lesion is diffuse glomerulosclerosis. Fourth lesion is nodular glomerulosclerosis. The nodular glomerulosclerosis is the most pathognomic feature and most specific feature of diabetic nephropathy. In vascular lesion, we may find hyaline arteriosclerosis. In tubular and interstitial lesion, pyelonephritis can be seen and interstitial fibrosis can be seen in last advanced case. Then we'll start from nodular glomerulosclerosis. As I have told you, it is the most pathognomic or specific feature of diabetic nephropathy. It is also called Kimmel-Steele-Wilson lesion. Paul Kimmel-Steele is the scientist and he is the pathologist who discovered the nodular glomerulosclerosis with Clifford Wilson, who was the English physician. They both discovered this nodular glomerulosclerosis. In this, there is a hyaline nodules deposit in the glomeruli, and they are the ovoid circular hyaline deposition in the mesangium, and they are surrounded by the capillaries. And so, as we can see here, this is the mesangium. This is the overall glomeruli. And this is the glomerular basement membrane. These are the glomeruli. Here is the capillaries. These wide spaces are the capillary. These are the capillaries. And between capillaries, there is a mesangium matrix, which is normally present. But in mesangium matrix, there is a deposition of spherical, ovoid, nodular, laminated, acellular hyaline, which is a pass positive. And this slide is from pass positive state. So they are showing pass positive state. And you can also see here, there's a deposition of acellular hyaline in glomeruli. And this is in Mason trichrome iron stain. So as these deposition is surrounded by the small capillaries, so due to this, it also called intercapillary glomerulosclerosis. And you can also see here, there is a thickening of the GBM. This is the basement membrane. You can see there is a prominent GBM basement membrane. So this is also a feature of nodular sclerosis. And there's also thickening of the vessels outside. So this is also a feature of the nodular glomerulosclerosis. And now, diffuse global glomerulosclerosis. It is a hallmark lesion. However, nodular glomerulosclerosis were a pathognomic feature or specific lesion, but it is a hallmark lesion. And it is in early stage, however, nodular is in late stage. So in the diffuse, what is the term diffuse means? If there's a more than 50% of the glomeruli involved, then we called it diffuse. And global means if whole tuft of the glomeruli involved, we called it global. And glomerulosclerosis is the thickening. So it is the uniform, diffuse increase in mesangium matrix. There is a uniform diffuse increase in mesangium. There is an absence of capillaries. There are no capillaries visible. So this is a diffuse increase in mesangium matrix. Along with the GBM thickening, there is a glomerular basement membrane thickening also. So this is the diffuse global glomerulosclerosis is the feature of diabetic nephropathy. However, diffuse proliferative glomerulonephritis is the feature of glomerulonephritis in that there is a more than 50% of the glomeruli involved, but there's a proliferation. In that, there's a hyperproliferative mesangium. However, here there is a very occasional cells are visible. So this is a diffuse global glomerulosclerosis. Now, the other glomerular lesion are insudative lesions. And these are very important question for PG are the capsular drop or fibrin cap. So insudative lesion form due to the leakage of the serum protein in the capillary wall. If these leakage get deposit in a capillaries, then it is called fibrin cap. This is the capillary, and these plasma proteins are, if deposit in a capillary, it is called fibrin cap. And if it is deposit in Bowman's capsules, then it is called capsular drop lesion. And the fibrin cap is a misnomer because there is no fibrin, it's just a hyaline. So fibrin cap is deposition in a capillary, and capsular drop is the deposition in Bowman's capsules. Then hyaline arteriosclerosis. This is also one of the important feature of diabetic nephropathy. In this, there is a deposition of hyaline in the afferent arteriole and the efferent arteriole. Then tubular and interstitial lesion. There is a thickening of the basement membrane is clearly visible in this slide. This is the past positive glomerular basement membrane, thickened basement membrane, prominent. And in advanced case, we can see here the small tubule, and which is showing tubular atrophy along with some chronic inflammatory cells, and fibrosis also are visible. So this is a pyelonephritis case, and in advanced diabetic nephropathy. So this is a feature on fluorescent microscopy. You can see here the prominent basement membrane, and tubular membrane also is prominent, and it is due to the deposition of IgG, immunoglobulin G, across the basement membrane. This is the feature in diabetic nephropathy. Now, stages of the diabetic nephropathy. The first stage is hyperfiltration stage. In this, the GFR is get increased, and in stage 2, there is a silent stage in which only basement membrane get thickened. In stage 3 called incipient nephropathy. It means slowly developing nephropathy. In this, microalbuminuria, which is around 30 to 300 milligram per day. And stage 4 is overt nephropathy, in which macroalbuminuria found for more than 300 milligram per day albumin. In stage 5, there is an end-stage renal disease. It's a progressive decrease in GFR. And end-stage renal disease, in this, there's a GFR will be less than 5% of the normal GFR. Then clinical feature. A for albumin. Mnemonic is albumin. A for albuminuria. Due to albuminuria, there's a swelling in the ankle, feet, and hand. Loss of appetite, high BP, urine may no cast in early cases. However, there can be a seen cast in late age, like in pyelonephritis, we can see WBC cast. Then muscles cramp and weakness. Then itchy skin. Then nephrotic syndrome in late stage. Nephrotic range proteinuria can be seen in late stage. So ADA screening recommendation. History and the physical examination is the most important. And then we can do a most specific test, which is a urine albumin creatinine ratio. It is done by the spot urine. And for UACR, we have to do twicely. It should be positive twicely out of 3 samples over 3 to 6 months to confirm as per the ADA guideline. Then serum creatinine, and then eGFR. eGFR is calculated by there is a formula of this. We can calculate by a formula. Then there is a sonography. Sonography preferred over CT to measure the kidney size and obstruction. Why? Because sonography can detect early structural change. However, CT can be used for measurement of the kidney and for blood vessels. Then kidney biopsy. Kidney biopsy is not recommended in diabetic nephropathy unless it is cause is non-diabetic. So it is only for the non-diabetic nephropathy. So UACR is defined is underlying in a category A1, A2, and A3. If if albumin is less than 30 milligram per gram, then it is normal to mild increase. If it is 30 to 300 milligram, it's a moderately increase. If the albumin in urine is more than 300, it's a severely increased. Indication of kidney biopsy. Kidney biopsy reserved for the non-diabetic kidney diseases. What are the indication of kidney biopsy? Is the absence of diabetic retinopathy. Why? Because diabetic retinopathy has very strong association with the kidney disease. So if one patient is not having diabetic retinopathy and he has some kidney changes, then you have to first exclude the diabetes case. We have to think for some other cause. Then sudden onset proteinuria, because in diabetes there is a progressive increase in proteinuria happened. Then rapid decline in renal function. But in diabetes nephropathy, the renal function will be slowly decline. And if active urinary sediment found in urine, because usually no active urinary sediment found in diabetic nephropathy. In short duration, if the complication develop in less than 10 to 15 years, then we can think for some other cause. In that condition, we can do kidney biopsy. And if diabetic nephropathy nephropathy present with some atypical clinical feature like fever, rashes, vasculitis, then we can do kidney biopsy also. Then treatment strategy. In diabetic nephropathy, the main important treatment is ACE inhibitor or angiotensin receptor blocker, because they act on they block the angiotensin 80 to angiotensin type 2, which ultimately cause constriction of efferent arteriole. So due to the ACE inhibitor, there is a vasodilatation of the efferent arteriole. And due to this vasodilatation, the pressure which develop in a glomeruli, it will relieved in diabetic nephropathy. So it ultimately improve the renal function. And then SGLT2 inhibitor, which is dapagliflozin, which cause decrease in sodium reabsorption at PCT. So if sodium reabsorb, most of the sodium get reabsorbed in a proximal convoluted tubule. And the SGLT2 inhibitor, they cause less reabsorption, which ultimately cause less secretion of renin. Ultimately, if renin is not secreted, then there's then efferent arteriole vasoconstriction will be delayed and the renal function will be improved. Then we have to do tight glycemic control. Then diabetic neuropathy. Diabetic neuropathy is the most common chronic complication of the diabetes, and almost 50% of the patient with long-standing case, they develop neuropathy. And distal symmetrical polyneuropathy is the most frequent form of diabetic neuropathy, in which distal part of the limb getting involved, and it also shows glove and stocking pattern of involvement. Then sensory symptoms predominate the motor and autonomic symptom. Pathogenesis. There are two main pathogenesis. First is microvascular ischemia, and in this there is a damage to the vasa nervorum. Vasa nervorum is the blood vessel who supply the small nerves, peripheral nerve. So if there is a damage to the vessel who supply the nerve, then the nerve finally got infarct and they have some changes like axonal injury, and we will discuss in further slides. Now, the other metabolic causes are the hyperglycemia-induced metabolic injury, in which there is a oxidative stress, which cause mitochondrial damage, and ultimately protein kinase C stimulation, which cause vascular endothelium growth factor secretion and growth factor release. So there is a damage. Finally, there is a damage in the endothelium. So type of neuropathy, there is a 4 type of neuropathy in the diabetes. One is a distal symmetrical polyneuropathy is the most common, then autonomic neuropathy, then diabetic lumbosacral radiculoplexus neuropathy, which is also called diabetic amyotrophy, and then mononeuropathy. Distal symmetrical polyneuropathy. It is the most common neuropathy, and there is a distribution is stock and glove, both palm and both foot getting involved, and the sensory symptom begins in a feet and then it progresses upward. The most common symptoms in distal symmetrical polyneuropathy is the numbness in a feet, tingling, burning pain, loss of vibration and sensation. And the sign is the most earliest sign found is the reduced ankle reflex. This is the most first sign we can examine in diabetic neuropathy. And then loss of proprioception, touch, and then risk of foot ulcer is there. Autonomic neuropathy. In autonomic neuropathy, diabetes involved both sympathetic also and parasympathetic nerve also. However, parasympathetic involvement is more common than sympathetic. So in cardiovascular, we can find resting tachycardia, orthostatic hypotension. In GI system, we can find gastroparesis. It means delaying in the emptying of the stomach, and then diarrhea. In genitourinary, the erectile dysfunction and bladder dysfunction. In pseudomotor involvement, we can find abnormal sweating. Now, diabetic radiculoplexus neuropathy, which is also called diabetic amyotrophy. The meaning of amyotrophy is the wasting of the muscles. So, the lumbosacral blood vessel plexus involvement cause ischemia in femoral nerve or obturator nerve. So, and the femoral nerve and obturator nerve supply in a proximal thigh muscle. So, the involvement of the muscle is proximal in diabetic radiculoplexus neuropathy. However, in distal symmetrical polyneuropathy, there is involvement of distal muscles. So, there is a painful proximal muscle weakness happen in diabetic amyotrophy, and it usually affect the upper limb muscles, thigh and hip. Then mononeuropathy. Diabetes also involves single nerve. So the most three nerves are the most important involvement. One is a cranial nerve 3 palsy, which supply in a extraocular muscles, and the intraocular muscles is the oculomotor nerve involvement, or there's a median nerve involvement which supply the lateral forearm or the lateral 2/3 of the palm, and the peroneal nerve which supply the anterolateral aspect of the leg. And the mononeuropathy are the usually of sudden onset, and it's self-limiting. Now, peripheral nerve structure. So this is the peripheral nerve trunk. In this, we can see here there's a bundle, there's a fascicles of the nerve. In these fascicles, we can see numerous axons. These are the small blue axons, and each axon is surrounded by the endoneurium. Endoneurium is the surrounding layer of the axon, and these fascicles are surrounded by perineurium, and then this nerve trunk is surrounded by the epineurium. So there is a blood vessels under the epineurium. Now, histopathological findings. The first finding is axon degeneration. Whenever there is a endothelium damage of the vasa nervorum, which supply the axons, there is a degeneration start. So there is a vacuolation. You can see the vacuolation changes, and these are the axon. So there is a vacuolation, and there is a clearing can be noted due to the phagocytosis. So there is a damage in the axon is clearly seen. Then segmental demyelination. In second stage, there is a demyelination. It means the myelin sheath got damaged. So there you can see here in this slide, there is a small, you can see a small thin outline. So there is a thinning of the myelin sheath, but axon is preserved. This center part is axon and the covering is myelin. So when segmental demyelination start to develop, there's a significant slow nerve conduction velocity. Then slowly, there is a loss of myelinated nerve fiber. So in this slide, you can see this is a normal slide. In this, you can see large nerve, large axon, and small axon. But in diabetic, in this nerve fiber, which is involved in diabetic neuropathy, you can see the large axon are damaged. There is a very few large axon are visible, and mostly small axons are visible. So there's a damage in the large nerve fiber, which takes place initially, and the small fiber damage takes place a little late. So when there's a loss of myelinated nerve fiber, in this case, the patient lost the vibration sense and the proprioception sense. Now, the basement membrane thickening. So this is the vasa nervorum who supply the nerve. You can see this is a normal blood vessel of the nerve. This is tightly adhered by the junction, and there is a normal pericyte, a normal basement membrane. But in this damaged nerve, damaged blood vessel, you can see there is a thickening of the endothelial cells, and there is a basement membrane alienation is also poor. So these changes cause due to the damage in the vessels. Now, endoneurium microangiopathy. In this, we can see a hyalinization of these are the blood vessel. So there is a thickening of the blood vessel clearly visible. There is a hyalinization and narrow vascular lumen, and with loss of pericytes, result nerve ischemia. The clinical feature of peripheral neuropathy. In the most important symptoms which patient told usually is the walking on a cotton, or a burning sensation, or pain on the touch, or pins and needle sock sensation, and tingling or numbness in hand and feet. Then autonomic neuropathy. In autonomic neuropathy, we can see orthostatic hypotension. This is this hypotension can happen from lying down to standing. If there is a fall of systolic BP of more than 20 mmHg or diastolic more than 10 mmHg, it is called postural hypotension. And the other autonomic neuropathy in diabetes is gastroparesis. It means delaying gastric emptying delaying. This is due to the damage in a vagus nerve, because vagus nerve is responsible for the antrum constriction. Then erectile dysfunction, and then bladder dysfunction. Bladder dysfunction because of detrusor muscles, the detrusor muscles involvement in the autonomic neuropathy. Then prevention and management of the neuropathy. So we have to do strict glycemic control is the single and most effective strategy. Target should be the fasting blood sugar should be 80 to 130 milligram per day, and postprandial should be less than 180 milligram per dl, and HbA1c should be less than 7% according to the ADA guideline. However, HbA1c can be up to 6.5% in young patient and if diabetes is of short duration. But if HbA1c in old age patient, if we make correct to till 6.5, then it can cause a hypoglycemia. So HbA1c less than 7% is the standard ADA goal. Lifestyle modification, the regular exercise, weight control, balanced diabetic diet, and to avoid smoking and alcohol, because smoking causes worse microangiopathy and alcohol is the neurotoxic. In smoking, there's a nicotine which ultimately causes damages the endothelium by increased reactive oxygen species. And in alcohol, the ethanol can directly damage the nerve fibers. Control of risk factor. So hypertension, dyslipidemia, and obesity are the three most important risk factors. We have to correct this. And regular clinical bedside tests are the 10G monofilament test. In this, we use a 10G monofilament small fiber, and we have to put it over a sole of the patient at 5 point, and we have to give pressure till it get bend, and we have to stop there for a 1 second. After 1 second, we can remove it, and then we have to ask patient is there is any sensation or not. So this is the primary bedside test which can give which can give us a clue for peripheral neuropathy. Then vibration sense, it can be done by 1 to 8 hertz tuning fork, then pinprick and temperature sensation, then ankle reflex, Achilles, it lost very early. Then nerve function test. The nerve conduction studies are the gold standard test which show the decreased nerve conduction velocity. And this decreased nerve conduction velocity is more common in demyelinating neuropathy. However, decreased amplitude in nerve conduction study is more common in axonal neuropathy. So we can differentiate from nerve conduction study that patient having demyelinating neuropathy or axonal neuropathy. So electromyography can also be performed and it detects the denervation or muscle involvement. Then test for small fiber neuropathy. If nerve conduction study is normal, but still patient having a symptom of neuropathy, then we can do a test for a small nerve fiber, which is a quantitative sensory testing. And we can do skin biopsy also, and in which we have to look for intraepidermal nerve fiber density. Then autonomic neuropathy test, which can be done by heart rate variability testing or postural BP measurement, which we have discussed earlier. Then management. In this, symptomatic treatment is for neuropathic pain, in which first line drug is pregabalin and gabapentin, which basically act on calcium channel blocker. And the other option is topical capsaicin cream and lidocaine patch. And foot care is the essential step for prevention of amputation in neuropathy. Now, for autonomic neuropathy, in orthostatic hypotension, we have to give fluid, we have to give compression stockings, and in gastroparesis patient, we have to advise small frequent meals and prokinetic drugs. In erectile dysfunction, we have to give phosphodiesterase enzyme 5 inhibitors, which ultimately cause increased cGMP, which correct the vasoconstriction effect, and it ultimately cause vasodilatation. So prevention strategy, tight glycemic control, blood pressure control, lipid management, and regular screening are the main preventive strategy. Then key take-home messages. Microvascular complication arises from chronic hyperglycemia, and the early screening is the critical step. Multidisciplinary management improve the outcomes. Now, some exam-oriented one-liner question I've prepared for you all, who all are giving exam. So the earliest lesion in diabetic retinopathy is the microaneurysm. The characteristic or pathognomic kidney lesion found in diabetic nephropathy is the Kimmel-Steele-Wilson nodule, which is also called nodular glomerulosclerosis. Most common neuropathy is distal symmetrical polyneuropathy. For microvascular complication, we have to screen annually cotton wool spot seen in diabetic retinopathy, but it also seen in hypertensive retinopathy and HIV retinopathy and SLE also. What are the first changes of diabetic nephropathy is the capillary basement membrane thickening. It is the first step and primary step in which basement membrane get thickened. Basement membrane of the glomerular capillaries. Now, most specific and pathognomic changes are nodular glomerulosclerosis. Diffuse glomerulosclerosis is the early lesion. However, nodular glomerulosclerosis is the late lesion. High albuminuria must be confirmed on at least 2 occasions, separated by 3 to 6 months. Then tight glycemic control reduce progression. Conclusion: diabetes causes significant microvascular morbidity, and the early diagnosis and the management reduce the complications. So thank you so much.
Thank you, Doctor. Doctor, is it possible to display the next slide? And yeah, thank you, Doctor. Thank you so much. And we are opening our Q&A session now. Please drop in your questions in the chat box. Doctor would be able to answer your questions. Doctor, I think we have few questions on the chat box already. I can read it out for you. Dr. O.P. Gautam is asking what chemicals can revert vascular changes, and what is the role of bariatric surgery to control DM vasculopathy? And he's also asking what is the relationship between DM and DVT?
What is the relation between
DM and DVT?
DM and DVT?
Yes.
DM.
Yeah.
Can I also, it's not visible. Question, can I also see?
Yeah, you can click on your chat icon, Doctor.
Okay. 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 Okay, so there's a many question. Okay, first question is what chemical can revert vascular changes? See, there is a no chemical because there is a no chemical who can revert the vascular changes. However, antioxidant can revert the early vascular changes, which can be occur in diabetes. And then, but the main effect or main way to revert the vascular changes are the same. They control the diabetes, and we have to control the hypertension and related complication. And what is the role of bariatric surgery to control the diabetes mellitus vasculopathy? See, in bariatric surgery ultimately work on a control in the weight of the patient. But if any patient who is already diabetic and he underwent for bariatric surgery, and if his blood sugar is not controlled, it cannot control the any vasculopathy unless his diabetes is under control. What is the relationship between DM and DVT? DM is the diabetes mellitus, and DVT is the vascular thrombosis, diffuse vascular thrombosis. Both are very different. In diabetes mellitus, the main issue is with the insulin, and in DVT, deep vein thrombosis, DVT is a procoagulant action. There is a thrombosis in the deep vein. Both are very different. And there are some more questions. Sir, how diabetes leads to prurigo nodularis? So it is a very chronic changes of the diabetic neuropathy, diabetes related skin complication.
Mm. Thank you, doctor. People are asking for certificate link. Doctors, the QR code is being displayed on your screen. You can scan the QR code to submit your form. Meanwhile, I've also dropped the link in the chat box. Your feedback means a lot to us. Please do feedback on the webinar and also fill the form to get your certificates. I am again telling every webinar, I keep telling this, please submit the form properly so that you get your certificates directly to your inbox. Sometimes it might also drop in spam folder. Please do check in spam folder. Thank you. And Doctor, you can still drop your question. Doctor would be able to read your question and answer your questions.
If there is any question related to this topic, you can still ask.
Suj, I have dropped the chat box again, the link in the chat box again. Please click on the form to submit the form. Dr. Pushpesh is saying, Doctor, excellent and very informative session.
Thank you so much for listening, and I would be very happy if someone getting my PPT, and if they get some knowledge from my presentation.
Thank you. Uh, iPhone, I don't know what's his name. iPhone says very excellent lecture. Dr. OP Gautam says excellent session. I'm dropping the certificate link again in the chat box. Please do click on the form to get your certificate. Doctors, also a small announcement. We have, I'll load 1 second. We have 3 more webinars lined up for you. We have one more webinar on 27th by Dr. Navanil Dutt, the ventilator blueprint, taming the ICU monster. On 29th March, we have webinar on how to choose a fluid for intravenous fluid resurrection by Dr. Rajesh Kumar Chand. On 31st March, we have reproductive endocrinology by Dr. Arshia Sayed. Please do follow us on social media to get all the form links. Let me also send you our social media channel links to follow us so that you can keep updated on all our webinars. Thank you so much. Doctor, we have one more question. Dr. Gautam Rai is asking, what is treatment for postural hypotension?
See, postural hypotension. The treatment of hypotension is the stalking. You have to give stalking, and also whatever. If there's you have to do electrolytes testing. If there is a issue with the electrolyte, you have to give that, and main prevention management is the stalking. You have to give stalking for postural hypotension.
Oh, thank you, Doctor, for answering that question. Dr. Gautam, I think you got your answer to that question. Dr. Jambavati also says, thank you, sir. Thank you, Doctor. On behalf of Mediversal Academy and the attendees here, I would extend my uh, heartfelt thanks to you for
Thank you.
connecting at this time and shedding your light on this particular topic. Thank you so much. We all, Dr. Anu says thank you, Doctor. Dr. M. Shravanti says thank you, sir. Thank you so much. The session was really informative. It was really learning. I learned a great deal, and I guarantee you that all the people here would agree with me. Thank you
Thank you
so
so
much for
much. Thank you so much.
and we are looking for more webinars from you, doctor. Thank you
Sure.
so much. And thank you all. Thank you, doctors, for joining us today. Please do follow us on our social media channels to get update on all our upcoming webinars. Thank you. Good night, all.
Thank you.